Thank you so much, Dr. Manish, and respected members of executive members of JSI and all the members present over here. We know whenever we are treating the patients with glaucoma, so many times they are using associated medications, they are having associated systemic diseases, and they show us that prescription that doctor मैं ये use कर रहा हूँ. So इससे कोई फ़र्क तो नहीं पड़ेगा हमारी anti glaucoma medication का. So that is why I thought of emphasizing on few important aspects of systemic diseases and medications which patients are using. Now, starting with one of a case of a 50-year-old female patient who was diagnosed with glaucoma 1 year back, and she had normal intraocular pressures on one anti-glaucoma medication which she was using, and the past ocular history had nothing significant except that past medical history revealed that she was hypertensive on medication, and there was no family history of glaucoma. But because recently she had a progression of glaucoma, and that is why she was referred to us. And on examination, the vision was 6/6 in both the eyes. Anterior segment examination was unremarkable with open angles on gonioscopy and normal central corneal thickness. We did a diurnal variation for her, and it was 14 to 20 millimeters of mercury in right eye and 12 to 18 millimeters in left eye. The examination definitely revealed glaucomatous cupping in both the eyes, and the visual fields, they revealed defect which was reproducible on the second visual field. Now the question is that despite the pressures being controlled, what are the other factors which can lead to progression of glaucoma? So we started the retrospective history. We inquired about snoring, and we know that snoring is associated with progression of glaucoma, but that was not present in that lady. Because she was hypertensive, so we put her on 24-hour blood pressure monitoring, and we know that nocturnal hypotension is associated with progression of glaucoma because of reduced in diastolic perfusion pressure. And what we found was that the lowest blood pressure recorded for that lady was around 4 o'clock in the morning, and it was 70 to 56 millimeters of mercury. So the thing is that then we had a discussion with her physician, and the medication was changed accordingly. She was on beta blocker, which was shifted to calcium channel blocker. So if we see this article from Survey of Ophthalmology, it shows that systemic hypertension is the most common association in the patients with glaucoma, followed by hypercholesterolemia, diabetes, and cardiac disease. Now, if we see the various medications which patients are using, most common one again are antihypertensives, along with antiplatelets and anticoagulants, followed by antihyperlipidemic agents and hypoglycemic agents. So we must keep these points in our mind that if the patient is hypertensive, there can be a history of nocturnal hypotension or obstructive sleep apnea, which might be associated with progression of glaucoma. So we need to get in touch with the physician and accordingly treat these conditions. The Baltimore Eye Survey and the Agna-Newmark study also find an inverse relationship between diastolic perfusion pressure and progression of glaucoma. The critical value which was found to be normal was 50 to 70 millimeters of mercury, below which likelihood of glaucoma progression increased dramatically. Now, if we talk about various antihypertensive beta blockers, we know that if added, a topical beta blocker, if added with systemic beta blocker, they lead to incomplete reduction of intraocular pressure. Moreover, systemic and topical, they produce an additive cardio-inhibitory effect. If the patient is cardiac patient, we need to be careful. Now, many patients, these are using thiazide diuretics, and they can sometimes lead to acute primary angle closure glaucoma because of forward shift of iris lens diaphragm, and the diuresis they induce, they can be increased by concomitant use of carbonic anhydrase inhibitors. So if we are giving Dimox to our patients, especially elderly male patients, we should be very, very careful that the diuresis they induce, and that may lead to significant discomfort, especially during this winter weather. Now coming to cardiac drugs. Now aspirin, which is very, very commonly used, which it can also sometimes lead to secondary acute angle closure glaucoma, again due to anterior shift of iris lens diaphragm. Besides leading to sometimes choroidal hemorrhage or exudative ARMD. Besides this, there is a case report of non-ophthalmic eye where warfarin led to bilateral ACG. So these points should be kept in mind because sometimes patient might present to you with these problems. One point I wanted to highlight in the patients who are using digoxin. Now, it is a known factor that beta blockers, they may interfere with binding of digoxin levels, and therefore they can lead to increased concentration and toxicity of digoxin, and therefore if patients on such medication, we need to monitor it very carefully. Rather, we should ask the physician to monitor it very carefully. Now coming to diabetes, we know that diabetes, there is a association in a increased incidence of glaucoma in diabetes, but neovascular glaucoma is common in PDR patients. But whenever we are using anti-hypoglycemic drugs, we need to be very, very careful because adrenergic agonists, they can decrease the effect of insulin and they can promote hyperglycemia. So again, we have to be careful. Then regarding systemic carbonic anhydrase inhibitors, they may increase the blood sugar levels of the patient because of the hypokalemia they induced. So kai bar patients, they say that Diamox khane se sugar बढ़ गई, but that actually can happen. So we need to be careful. And then we all know the glycerol has to be avoided in diabetic patients. Another case I wanted to highlight of a very 22-year-old female, and I'm sure that some of you must have seen these kind of case also, who was using spectacle for past 12 years, and she had a headache and she took some medication, and suddenly there was loss of vision, and she came to us with headache, nausea, vomiting, and very poor vision. So while examination showed that vision was hand movement in both the eyes, and she was severely photophobic, unable to open her eyes. Now, on slit lamp examination, we saw that there was bilateral circumciliary congestion with corneal edema in both the eyes and extremely shallow anterior chamber. And IOPs were in the range of 43 millimeters and 48 millimeters of mercury with mid-dilated pupil. So, as we see all these clinical features, it is a typical case of bilateral acute angle closure glaucoma. But sudden onset in a girl who was myope. So we looked out for causes of bilateral acute angle closure glaucoma, and we know that most common these are the systemic medications which can lead to such a situation. Besides general anesthesia, snake bite is another cause of bilateral acute angle closure glaucoma. Microspherophakia and Vokoyanagi-Haradas syndrome might be another cause. So we inquired the history of systemic medication with the girl, and when retrospective history revealed that she took topiramate for migraine, and which led to bilateral acute angle closure glaucoma. So this is again a very, very commonly used drug and not just this, there are several other drugs, antidepressants and anticholinergics, which can lead to this kind of situation. And many a times patients, they do buy over-the-counter drug and use these prescriptions like antipsychotic, tricyclic antidepressants, SSRIs, which are very commonly used nowadays, sedatives, which are although not available that easily without prescription, but patients do arrange. Then anti-Parkinsonism drugs and antispasmolytic are also can lead to this kind of situation. So what are the diagnostic feature? We need to do anterior segment imaging. UBM is the ideal for such a scenario, which might reveal these kind of dense area in the supraciliary area. Or you can do an ultrasound anterior that with water bath, if you can do, you can actually see this hypoperfused area. So management is to stop these drugs. Systemic and oral anti-glaucoma medication needs to be used. You can use topical anti-glaucoma depending on the intraocular pressure. It can be beta blocker, alpha agonist and carbonic anhydrase inhibitor. Prostaglandin analogs and pilocarpine has to be avoided because they can aggravate the situation. Topical steroids are must in such scenarios. Cycloplegics you have to give. Contrary to patients of pupillary block, here we need to give cycloplegics. But no laser eye dot mean these patients, and if you treat properly, many a times these patients, they tend to resolve.
Can you sum up? Because
yes, sir.
Already time is over.
Yes, sir. Sir, I will come to last slide. So to summarize, I would say, that we need to be observant about systemic issues and medications. Glaucoma, if progressive at now, normal intraocular pressure should be investigated for certain of the systemic medications. Sometimes 24-hour blood pressure monitoring is very, very important, and check for concomitant medication. Certain factors should also be considered, like patients doing Valsalva maneuver. And regarding pregnancy, I would like to highlight that treat it beforehand, before the patient gets pregnant. Thank you so much for your kind attention.
Thank you,